Good evening, everyone. I am Dr. Vats, A.K. Vats, neurologist from Udaipur. I have been allotted the topic of Vestibular Rehabilitation Therapy, the VRT, hereinafter called. So, what is VRT? VRT comprises of the physical therapies that encourage the head, eye, and truncal movements, accelerating the recovery of patients with acute or chronic peripheral vestibulopathy. It acts mainly by three mechanisms: enhancing the vestibular compensatory mechanisms and improving the vestibular hypofunction by reinforcing the vestibulo-ocular, vestibulospinal, and vestibulocholic reflexes, improving the general balance function and sharpening the balancing skills of the object, and enhancing the functionality of deranged part of the vestibular labyrinth or of a deranged mechanism of the vestibular system. It may be an asymmetric labyrinthine hyperfunction which occurs in BPPV. So the management of dizziness and vertigo, the available treatment options are drugs which may be non-specific like vestibular suppressant drugs, short period use, specific therapy for treating the specific underlying disorder like vestibular paroxysmia, we give carbamazepine or lacosamide, maneuvers for BPPV, and physical therapy which may be non-specific like Cochran-Coxe exercises or the virtual reality, or maybe organ-specific vestibular physiotherapy. The non-specific symptomatic therapy has a very short duration use of 3 to 5 days because it can impair the vestibular compensation. The Cochran-Coxe exercises have its limitations, which we'll see in the next slide. So we are left with the specific drug therapy to underlying disorders, maneuvers for BPPV, and organ-specific vestibular physiotherapy, and the newly emerging vestibular reality, VRTs. This slide is by the courtesy of Shri Dr. Vishwas from Kolkata. So non-specific physical therapy by tear-away sheets, which is very popular in our country, is this sheet, which is routinely given by many practitioners all over the country. However, it has got problems because most patients can't do the exercises properly as they are not trained by the professionals and perform the exercises at home. As a result, sometimes there is an improper stimulation of the vestibular system, which get used to the wrong inputs because of the inherent plasticity of the vestibular system. And this further leads to improper processing of the normal vestibular inputs, leading to maladaptation and imbalance. My talk is restricted to the VRT of subjects suffering from horizontal semicircular canal BPPV. Horizontal semicircular canal BPPV is a heterogeneous peripheral vestibular disorder. It exists in two forms, geotropic and apogeotropic horizontal canal BPPV. The geotropic is the one which elicits the geotropic horizontal positional nystagmus, which is bidirectional on lateral head roll to right as well as to the left during the supine roll test. And the apogeotropic elicits the apogeotropic horizontal positional nystagmus during the lateral head roll test of the supine roll test. So we need to know the pathology, what happens. The geotropic is almost invariably caused by canalolithiasis in the posterior long arm of the horizontal semicircular canal. However, the apogeotropic variant can be caused either by the canalolithiasis in the anterior arm of the horizontal semicircular canal, or it can be caused by cupulolithiasis, which may be either on the utricular side or on the canal side of the cupula. However, it is almost impossible to differentiate before where does the otoconal debris is adherent, either on the utricular or on the canal side. It is pertinent that we know the precise pathology, its lateralization as well as localization by the diagnostic supine roll test, which is also called the head yaw test. So with this pathology in background, we proceed to our first case, which is the geotropic variant. This is a patient, 19-year-old boy, had vertigo for 3 days. The supine roll test on lateral head roll to right elicits a geotropic nystagmus, quick component beating towards the lowermost right ear on lateral head roll to right. And on lateral head roll to left, it again elicits a nystagmus, which is geotropic, quick component beating towards the lowermost left ear. And it is stronger on lateral head roll to left as compared to that it was seen on the lateral head roll to the right. So this is the localizing sign, that is, it localizes to the left long posterior non-ampullary arm horizontal semicircular canalolithiasis. So this is now treated with the Guffoni maneuver. From short sitting, the patient is taken to the non-involved lateral recumbent position, maintained in this position for around 2 minutes, after which the head is inclined downwards like this, and this position is maintained for another 2 minutes, after which patient is uprighted to sitting position, completing one Guffoni maneuver. In our center, 2 Guffoni maneuvers are done for the geotropic variant, and a verifying supine roll test is done 1 hour after, which in this case did not elicit any nystagmus on lateral head roll to right, left, as well as to the right at 1 hour, and patient was free of vertigo. And this same identical findings was also noted at 24 hours. So this patient had a co-relief with 2 Guffoni maneuvers done in 1 session of treatment. How this works? This is the otoconal debris in the long posterior arm of the left horizontal semicircular canal. As the patient is taken to the contralateral non-involved recumbent position, the canal becomes vertical and the otoconia shifts towards the vestibule. And as the head is inclined downwards in the yaw axis, the otoconia enters into the utricle, thus clearing the canal and leading to cure. Another method of treating this patient could be forced prolonged positioning, FPP, which is the abbreviated form. If this patient is placed in supine position, the otoconal debris of the left long posterior arm lies like this. And if the patient is asked to go and sleep to the non-involved right side, what will happen is that due to the gravitational force, the otoconia here will gravitate into the utricle and will get dispersed into the utricular matrix, and this will lead to cure. This is a strategy employed by some of the groups in Italy who believe in minimal stimulus therapy and diagnostic test for treatment of BPPV. This is a case 2. This is the lateralization is difficult. This patient, 38-year-old, supine roll test elicits a lying down nystagmus. You can see that the nystagmus is beating towards the right side. So how did this nystagmus help me to lateralize? See, the lateral head roll to right elicits 2 to 3 beats of geotropic nystagmus. And on lateral head roll to left, again 2 to 3 beats of nystagmus, and it is almost impossible to decide which is the stronger nystagmus. However, it is known that the lying down nystagmus, which is a secondary sign of localization and lateralization, beats towards the contralateral side in cases of the geotropic variant of the horizontal canal BPPV. So this is a exemplary diagram. This is the long posterior arm of the left horizontal semicircular canal. As the patient is taken to the supine neutral position, the otoconia shifts ampulofugal, and so does the cupular deflection occurs. And that is why, according to the Ewald's law, the lying down nystagmus feeds to the contralateral right side. So this patient was treated with Guffoni maneuver. From short sitting, he is taken to the non-involved right lateral recumbent position, then head inclined downwards, and the second position is maintained for 2 minutes, after which he is uprighted to the short sitting position and completing the Guffoni maneuver. 2 Guffoni maneuvers done in this patient, and at 1 hour, the patient did not had any nystagmus, either lying down nystagmus or any nystagmus on lateral head roll to right or to the left side, and patient was free of vertigo. And the same findings of non-existing nystagmus and vertigo were also observed at 24 hours. So this is a patient where the symmetrical strength positional nystagmus on lateral head roll was elicited, and the secondary sign of lateralization helped us to reach the lateralization. So this was published by us. We had around 35 patients, in which around 46% of patients with horizontal semicircular canal BPPV had lying down nystagmus, 50% those with geotropic, and 28% with apogeotropic horizontal canal BPPV. Case number 3 is apogeotropic variant. This is by short anterior arm canalolithiasis. 28-year-old lady, vertigo for 3 days, lateral head roll to right, left, right, elicits a very strong nystagmus. On left also it elicits a nystagmus. Sorry, I show this again. This is a lady. Apogeotropic nystagmus. Quick component is beating away from the lowermost right ear. It is apogeotropic. And the lateral head roll to right also elicits an apogeotropic nystagmus, but this is weaker as compared to that seen on the right lateral head roll. So the side that elicits a weaker nystagmus in the apogeotropic variant is the disease side. And because the patient had nystagmus duration of less than 1 minute, the disease side was considered to be the left side. So this patient has short anterior arm canalolithiasis of the left horizontal semicircular canal, and accordingly she was treated with Appiani maneuver. From short sitting, she is taken to the ipsilateral lateral recumbent position. After 1 minute, the head is inclined upwards in the yaw axis, and this second position is maintained for 2 minutes, after which the patient is uprighted to the short sitting position. Again, 2 Appiani maneuvers are done in our center, and a repeat supine roll test was done after 1 hour, which elicits on lateral head roll to right a very faint geotropic nystagmus, and on lateral head roll to left it elicits a stronger geotropic nystagmus. So what has happened to this patient? This patient has transformed from short anterior arm canalolithiasis of the left horizontal semicircular canal to long posterior arm canalolithiasis of the left sided horizontal semicircular canal. Accordingly, now she is more amenable to treatment. She was treated with Guffoni maneuver. What happens with Appiani maneuver? This is a otoconal debris in the short anterior arm of the left horizontal semicircular canal. As the patient is taken to the ipsilateral lateral recumbent position, the canal becomes vertical, and the otoconal debris, it shifts towards its posterior end. And as the head is inclined upwards, the debris moves further towards the utricular exit. In some cases, it enters into the utricle and clears the canal, thus leading to direct cure after the Appiani maneuver. However, more often than not, it just shifts from the anterior to the posterior arm of the horizontal semicircular canal, thus leading to the conversion to the geotropic variant, which occurred in this patient. And she was then subsequently treated with Guffoni maneuver. This I am running forward. Right lateral recumbent, which is the non-involved side of this female, head down, inclined 45 degrees for 2 minutes, uprighted, 2 Guffoni maneuvers, and after 1 hour, this is how the Guffoni maneuver works. This we have seen with first patient exactly how it clears the canal. And verifying supine roll test done did not elicit any nystagmus on lateral head roll to left. no geotropic or apogeotropic nystagmus, and on lateral head roll to right. And the patient was free of vertigo, and the same identical symptom-free supine roll test without nystagmus elicitation was seen at 24 hours. Another option in this patient could have been a two-staged forced prolonged positioning. If this patient would have been asked to lie on the ipsilateral lateral recumbent position, this is the position of otoconia in the anterior arm of the left horizontal semicircular canal. If she would have lied on the involved side on day 1 for 12 hours, the otoconia would have moved towards the posterior arm. And if at this moment she converts into the geotropic variant, the first thing we can do is to do a Buffoni maneuver and see a repeat verifying supine roll test. However, the another option is the lateral recumbent position to the non-involved side on day 2. And so this will now gravitate and go and get dispersed into the utricle, which is here. So this is the therapy for the people who are very sensitive, and for this is practiced by an Italian group by Esprella, where they believe in the minimal stimulus treatment. This is a case 4. This is a 33-year-old female, had vertigo for around 7 days. Lateral head roll to right elicits a apogeotropic nystagmus, and this apogeotropic nystagmus was of long duration on lateral head roll to right. It was of more than 3 minutes duration. I am scrolling it forward to 3 minutes. Still it is present. And on lateral head roll to left, again an apogeotropic nystagmus of 1 minute duration was seen, quick component moving away from the lowermost left ear, but this is weaker as compared to that elicited on the right side. So this is a left-sided cupulolithiasis. 3 supine roll tests done in this patient did not change the character of the nystagmus, either its duration or its polarity. So this was a case of cupulolithiasis. So this patient was treated with head shaking maneuver. From short sitting, the patient was taken, the head was anti-flexed around 30 degrees and shaken side to side 30 degrees for 30 seconds. And after 1 hour, a verifying supine roll test was done, which did not elicit any nystagmus on lateral head roll to right, as well as to the left, and the patient was free of vertigo. A patient was called 24 hours later, and similarly a supine roll test was repeated, which did not again elicit any nystagmus, and patient was free of vertigo. So how does the dramatic response to head shaking maneuver indicates that the patient suffered from the cupulolithiasis on the utricular side of the cupula. So how does it act? This is a patient who is having a otoconal debris adherent to the utricular side of the cupula. As the patient shakes his head violently, the inertial forces generated disengage the adherent otoconal debris, and as it disengages, it disperses into the utricular matrix, leading to immediate cure, which happened in this case. So there is a slide of post-prolonged positioning in cupulolithiasis. However, its efficacy is questionable. This is a patient who has a cupulolithiasis on the canal side. If the patient is made to lie in the ipsilateral forced prolonged positioning, there are chances that this may disengage and fall into the canal under the effect of gravity. However, the contralateral FPP would be ineffective. Likewise, in cupulolithiasis on utricular side, the contralateral FPP is likely to be effective because here we have a chance that the otoconal debris gets detached and disperses into the utricle, while the ipsilateral FPP in cup-Q variant of the cupulolithiasis is likely to be ineffective. However, the big question is that there is no single method, clinical, radiological, or by any vestibular testing methods to know whether the otoconal debris is either on the canal or to the utricular side. And secondly, they are mostly adherent very tightly to the cupula. So a head shaking maneuver before a force prolonged positioning may be useful in such cases. We have suggested an algorithm for elicited apogeotropic positional nystagmus. Supine roll test elicits apogeotropic positional nystagmus. Less than 1 minute duration. It is repeated supine roll test multiple times, at least 3 times in our center. It transforms to geotropic variant in almost 99% of the cases. It indicates transformation of short anterior arm to long posterior arm canalolithiasis of the horizontal semicircular canal, which can be treated with Buffoni, barbecue roll, or force prolonged positioning. If the supine roll test elicits more than 1 minute duration apogeotropic positional nystagmus, we repeat supine roll test multiple times, at least 3 times. If it is still apogeotropic, highly suggestive of horizontal semicircular cupulolithiasis, we do a head shaking maneuver as we did in that patient. If they repeat SRT supine roll test, the nystagmus disappears, it is highly likely that patient suffered from the cupulolithiasis on the utricular side. If it transforms to the geotropic on repeat supine roll test, it is suggestive of cupulolithiasis on canal side, which can be taken care by Buffoni, barbecue roll, or force prolonged positioning. And if it is still apogeotropic on repeat supine roll test, the possibility is that the otoconia are tightly adherent to the cupula, or there is an alternate diagnosis. This could be a central paroxysmal positional vertigo due to a pathology in midline cerebellum, especially the nodulus. This finishes my presentation. Thank you.
Thank you, Dr. Vats. It was a very, very interesting demonstration.
Yes.
I think we'll now start off with the session. Is Dr. Kothari in now?
No. So, Dr. Banerjee, just an update. We'll first finish off a few questions that we have for Dr. Vats.
Yes.
And following that, then we can go to the panel discussion for the red flags.
Right. Lovely.
Yeah.
So I think it was very well illustrated, Dr. Vats. So I'll ask you a couple of questions which has come from our participants. One question is, do you advise vestibular rehabilitation exercise in all patients of BPPV? That's the first question.
Certainly not. Certainly not, because I follow up these patients at 2 short follow-ups. Can you hear me?
Yes.
I call them after 1 hour for a repeat positional test, whether it is what was the original problem was, whether it was a vertical canal BPPV or whether it was a horizontal canal BPPV. If the patient does not have any elicitation of nystagmus or any other thing, vertigo during the supine roll test, I again call them after 24 hours to look for the elimination of nystagmus and vertigo. So at 2 short follow-ups, 1 at 1 hour and 1 after 24 hours. If the patient does not have any nystagmus or vertigo during elicitation of the supine roll test or Dix-Hallpike test, I send them patient even writing a single medication. I don't write any vestibular suppressant drugs. Many such patients, they would come to you after a few days. This could be a recurrence. This could be a canal switch. or it could be a post-BPPV syndrome. Actually, you cannot make the diagnosis of triple PD at least when 6 months have gone. So short of that, we make a diagnosis of phobic postural vertigo, which is a similar entity or which has now emerged with the triple PD. So in such cases, the exercises for the vestibular rehabilitation, which are basically we give by the tearaway sheets, which I that I give by a video demonstration, or better by a face-to-face demonstration that I give. Routinely, I don't prescribe any vestibular rehabilitation therapy other than the specific positional manuals.
I think the next question is on the same line. What should be the correct time to start with vestibular rehabilitation exercises in patients with BPPV?
Sir, again, the question is that we are doing a specific repositioning maneuver to take off the asymmetrical stimulation of the vestibular labyrinth, because either the canal is having a movable clot, which is in canalolithiasis, or there is a heavy cupula. In any case, there is an excitation on one side, which is causing a vestibular asymmetry and leading to vertigo. So once we take care of that, we don't have a possibility of a true vertigo. I mean, the spinning vertigo. The thing is that many such patients become, with time, they have problems with anxiety. Some have psychosomatic components. Some people have real problems. And this could be one reason that some of the papers have found that there is a primary pathology of the utricle. They have found in some studies that the VAMP studies are abnormal in patients with BPPV. So the one theory is that some groups have found that it could be a primary abnormality of the utricle that has led to ejection of the otoconal debris into the canal as far as the canalolithiasis is concerned. So that is a matter of research, and there are no large scale studies to address that. So vestibular rehabilitation therapy of enhancing the vestibulo-ocular, vestibulo-colic reflexes is done only when the patients have problem with non-spinning vertigo after correction with maneuvers.
Yeah, I mean, how long should the rehabilitation exercise be advised? That is the last question. So it all depends on how the patient improves, isn't it?
Yeah, yeah. Definitely.
Right.